Okay, we're continuing the respiratory system. So this next section is talking about the respiratory volumes. So the amount that we actually do ventilate. In the previous video, we talked about how we ventilate. Now we're going to talk about how much we ventilate. So there are different volumes within the lungs. There's 4 volumes, and then we'll see there's some capacities that are combinations of these volumes. The amount of air that we normally take in with one quiet breath and let out is called the tidal volume. It's the amount of air that moves in and moves out, moves in and moves out like the tides. Now, that's obviously not all the air that the lungs can take. If you were just to take a normal breath in and then hold it for a second and then try and take in more, you can fill your lungs far above what you normally do at the end of a normal inspiration. So there is this inspiratory reserve. This is the amount of air you can breathe in, but you normally don't, unless you're trying to take a deep breath, unless there's a reason to take this and move up into the inspiratory reserve. So normally the tidal volume is about 500 mils up and down. You can take more in for the inspiratory reserve. But if you take a normal breath and let it out normally, and now blow, like you're going to blow out candles, there's more air that you can expire, but you normally don't. You can, but only if you're blowing up a balloon or something do you move into this expiratory reserve. A normal quiet expiration, just the relax without a forced expiration, ends, and then there's still more that you can blow out if you have to. That's called the expiratory reserve. Now there's a certain amount of air that's left in the lungs no matter what. You can't blow it out. You can't, it's there. And that's called the residual volume. It's the volume of air that is there all the time, no matter what. You have no choice in that matter. Okay, so the tidal volume is normally about 500 mils in both men and women. That brings enough oxygen for quiet ATP production. The inspiratory reserve is about 3+ liters in men. In women, it's a little bit less. But this has more to do with body size than gender. A 6'2", 200-pound woman will have more like will have a much larger lung capacity than a 5'4", 120-pound man. So like it's more to do with body size. The expiratory reserve, about 1,200 in men, 700 in women. Residual volume, about 1,200 in both. Now, really, these things can be combined. So at the end of a normal exhale, the tidal volume exhale, the amount of air that's still in the lungs is the residual volume plus the expiratory reserve. So functionally, That's the residual. There's the residual you can't get rid of, and then there's the residual that you can, but you don't, the expiratory reserve. So functionally, there is a residual capacity. And so we're going to start talking about the capacities. So all four of those volumes put together make the total lung capacity. So that's the amount of air from completely empty collapsed lungs to absolutely full, any more air and it bursts, is the total lung capacity. And we'll call it about 6 liters. Now, if we look at how much air we actually can move, being alive, it's everything except for the residual volume. So we'll call that the vital capacity, vital meaning alive, because the only way to get rid of the residual is have completely collapsed lungs. So the vital capacity is the inspiratory reserve, the tidal volume, and the expiratory reserve, the three of them together. I've already mentioned the functional residual capacity. That is the residual volume plus the expiratory reserve, because functionally it's what's residual, what's left over in the lungs at the end of a normal expiration. The inspiratory capacity is the tidal volume plus the inspiratory reserve, because it's the amount that you can breathe in after a normal exhale. So there's the amount that you do breathe in and the amount that you can, but you normally don't. So those together are the inspiratory capacity. So if we look at these, the total lung capacity about 6, vital capacity is about 4,800 because there's about 1,200 in residual. The inspiratory is about 3,600, which is the 31 of the reserve and 500 of the tidal volume. The functional residual is about 2,400 in that it's about 1,200 residual and about 1,200 expiratory reserve. So if we pull this all together on a graph, it looks like this. Now this is what a spirometry looks like. This is a spirograph. Now with these things, you actually read them from right to left, not left to right. So you start here and you move along this way. So this is the tidal volume in, tidal volume out, tidal volume in, tidal volume out. Now expiratory reserve. And the total vital capacity, right from the residual volume to full, let it out, let it in, and let it out. So, the 4 volumes, functional residual, these 2. Inspiratory, these 2. Vital capacity, these 3. Total lung capacity, these 4. Now, this is a concept that a lot of people for some reason have trouble with, and I don't quite understand. But some of the air that you move never actually gets to the respiratory bronchioles in the alveoli. Like, so I exhale, air goes out, then when I inhale, I pull all this air into my respiratory system. But some of it doesn't get any further than my nose when I stop inhaling. Some of it is in the pharynx, some of it's in the trachea, some of it is in the primary bronchi. You know, it kind of stops there. So the volume of the tubes that get to the respiratory zone don't contribute to gas exchange because they're still in the conducting zone, but that air still has to be moved. We call this dead space. If you were to go snorkeling, the air that's in the that's in the tube of the snorkel would contribute to the airspace. That's air that you have to move, but you don't actually get any gas exchange from it. You have to blow it out. When you exhale, you have to suck it in when you inhale, but it never gets all the way. So everybody has a certain amount of anatomical dead space. And for most of us, it's around 150 milliliters. And that's just the lumen of all the bronchi and the trachea. It's the volume of the conducting zone, pipes. Now, we can have stuff called alveolar dead space. Now, this is in pathology. So if you have emphysema and some of the alveoli are dead, air still has to move in and out of them, although no gas exchange happens there. So that is alveolar dead space. That stuff is pathology. The anatomical is not. That's normal. The total dead space is the anatomical plus whatever pathological dead space you have. So we use the spirometer to measure these volumes and these capacities so that we can assess how the lungs are working. Now, one of the good things the spirometry can do, they can distinguish between the obstructive diseases and the restrictive diseases. So in an obstructive disease, you are really, it's the tubes are being blocked, so you're not exchanging the air. In the restrictive disorders, the total lung capacity is lost, and so therefore the volumes are lost because of scarring and the lungs not being able to expand. So an obstructive disease would be things like COPD, chronic obstructive pulmonary disease. So that would be chronic bronchitis or something. It also is asthma can be an obstructive disease. The restrictive disorders are things like fibrosis, which is scarring of the lungs, so the lungs lose their elasticity. I'm very familiar with both. My father-in-law died of COPD, and my father died of pulmonary fibrosis. And it was interesting dealing with the family who thought, well, they both have lung disease and they're both on oxygen, so therefore they both must have had the same thing, where they had the exact opposite thing. One was obstructive and one was restrictive. Okay. When we start to test the function, we look at how much air can somebody move in a minute. So the total amount of gas flow in and out of the respiratory tract in 1 minute is called minute ventilation. So people, you just measure that. That's what the spirometer measures. You can have a forced vital capacity. So that is, you take as deep a breath as possible and exhale. So you take breath right into the inspiratory reserve and exhale right to the residual volume. So you're trying to measure the vital capacity, and that measures the vital capacity, right? We also look at forced expiratory volume, so the amount of gas expelled during time intervals of that. So we can measure how quickly you can get it out. So if it's there, the vital capacity is big, but it takes a long time to get through that vital capacity, then we know we have obstruction. If the vital capacity isn't as big as we expect, then we know that we have restriction. The lungs aren't as big. Now, there's much more nuance than that. So the increases in total lung capacity, force uh, and yeah, residual volume, all occur because of obstructive. You can't. One of the things that's interesting is that with these obstructive diseases, often the person can actually inhale just fine because inhale is an active thing. And so all you have to do is work a little harder and you can get the air into the lungs. But because normally exhaling is a passive thing, it's much more difficult to get air out of the lungs. So what ends up happening is the residual volumes increase because you can't get the air out. The functional residual capacity increases because you can't get the air out. And so you start breathing in, like the tidal volume starts moving into the area that would normally be inspiratory reserve. And because of that, the lungs get bigger. So you'll see people with COPD, they become barrel-chested. Because they try and make up for these by literally just getting bigger. The restrictive diseases, the vital capacity, the total lung capacity, the functional residual capacity, and the residual volume all go down because it's, instead of trying to blow air into a balloon where the balloon is going to expand, you're blowing air into a baggie. The baggie will inflate, but will reach a certain size and you can't take any more air. So the fibrotic restrictive diseases are like your lungs have gone from being balloons to being baggies, being plastic bags, and it's not pleasant. So we can measure this minute ventilation rate, and we can do that, but we have to calculate the alveolar ventilation rate because it really doesn't matter how much air you're moving. What matters is how much air are you moving that actually gets to the place where we can exchange gases. The alveola, basically, the respiratory zone, how much air are you moving in and out? And really, so minute ventilation is the frequency of breaths times the tidal volume. So breaths per minute times the milliliters per breath gives you milliliters per minute in the minute ventilation. But the alveolar ventilation rate, it's still the breaths per minute, but it's the amount of air that you've moved minus the amount of air that's in the dead space. So if your tidal volume is 500 and your dead space is 150, you're moving 350 mils of air to the alveoli per breath, and you multiply that by breaths per minute, and you have the alveolar ventilation rate in milliliters per minute. Now, normally the dead space is constant. And what it means is that rapid shallow breathing actually decreases the alveolar ventilation rate because you have to overcome the dead space more often. So here's a chart that actually works this out. So if we have normal breathing, so the normal rate and depth of breathing, if the dead space is 150 and the tidal volume is 500, you're actually getting to the alveoli 350 per breath. The respiratory rate is 20 breaths per minute, just for easy figuring. That means that you move 10 liters of air per minute in your minute ventilation rate, 10,000 milliliters per minute, which is 500 times 20. But the alveolar ventilation rate is 350 times 20, or 7,000. So it's about 70% of the air that you move you get to use. Now, if you slow your breathing down, so you take deep, slow breaths, what happens is you still have the 150 of dead space, but your tidal volume goes up. So for easy figuring, we'll call it 1,000. So that means that you have 850 mils is getting to the alveoli. You slow your breathing down to 10 breaths a minute. 1,000 per breath gives you 10,000 mils per minute, 10 liters per minute. But because you're getting 850 mils to the alveolar, your alveolar ventilation rate is 8.5 liters, so 8,500 milliliters per minute, or about an 85% of the air that you move actually is useful. If you do rapid shallow breathing, like you're excited or you're doing Lamaze or something like that, 150, but your tidal volume is small, so it's 250, so that means you're only moving 100 to the alveoli each breath. Your respiratory rate doubles, so you're at 40 breaths a minute. You're still moving 10 liters of air a minute. You just do it rapidly. But what it means is that because you're only getting 100 into the alveoli per breath, 100 times 40, is you're getting 4,000, which is 40%. So a few years ago, they used to have pregnant women do this breathing, and now it's not recommended because they realized that there wasn't enough oxygen getting to the baby when that happens, because you're only dealing with maybe less than 40% efficiency with the breathing. You know, that's why at yoga they tell you to slow down your breathing, take slow, deep breaths, be calm, right? Because you're getting a lot more effective ventilation at that slow and deep. Now, there are some non-respiratory air movements that we'll just throw in here to be complete. So this is things like yawning, sneezing, laughing, hiccups. We move this air, but it's not for ventilation purposes. We'll pick up the gas exchange, so external and internal respiration and transport in the next video.